All right, all right. Um, we talked a little bit before. Obviously, I know you because uh me and Daniel both are close, and we also know Trent. So since most of my audience are in Asia, can you like introduce a little bit?
Sure. My name is Bernard Condevaux. I'm a physical therapist. I've been a physical therapist for many years. We'll leave it at that. Um, Graduated from PT school in Detroit here at Wayne State University. And then career kind of went sports and leadership, same kind of way. And we're doing a little bit of both. I was a consultant for the Colorado Rockies and for the Colorado Avalanche. Worked in cycling with the U.S. national team, rally sports, quick step cycling, which was number one team in the world out of Belgium for a long time. Worked with them for many years. Went to 3 Olympic Games with the U.S. Olympic team, 4 Pan Am Games, and then out of the blue, got the opportunity to come to Detroit to work with the Detroit Pistons. Took that, did that for 4 years until 2022, and then after that ended, I went back and got my doctorate. And I went and after I got my doctorate, I started working independently, and I'm a consultant, and I work with primarily basketball players, but I also work with a Filipino wrestler who recently gold medaled, worked with a youth hockey team in Colorado, um, but again, primarily elite basketball players.
Nice, nice, nice. So you're gonna hate me, but obviously like 30 something years, 34, 35 years in this industry,
Yeah,
right? You've seen a lot, right? Like nowadays everybody have their DP, everybody's DPT.
absolutely.
Every organization wants some sort of strength coach that is like dual certified or whatsoever, dual credential.
Mhm.
So the first question I want to ask you is like, in your experience, uh, because all right, so we actually in the league, I think in the NBA, we actually have more and more soft tissue in the last like 10 years. And obviously we have more technology, we have more resources, organization are hiring more people. So what exactly are we missing?
Boy, that's an easy question to start with. Just throw
Okay.
the hammer at me. Well, I think it's interesting, actually. I remember early on with Detroit, we had a sports scientist, and we would have meetings, and they would go over a lot of the information that they got. And my question, not being a sports scientist, but having worked in cycling and all that, it's fairly forward in sports science. But my question is when you get a lot of data, what's actionable? So I think sometimes you get information, that's great. Is there anything I can do about it? No. In my opinion, that's noise. Let's focus on what we can control and make improvements there. I do believe that the scheduling, obviously, the league's a lot different. The pace of play is different than it used to be. I think players are coming in now. I used to have this conversation with coaches. If you look back in the day, I had talked to some of the guys who had been part of the bad boys back in the late 80s, early 90s. And what they used to do in the off season, play some pickup, have some beers, hang out at the beach, relax, put on some weight. You had a month-long training camp, you got yourself back into shape, you got ready to play. Back in those days, hey, you score 85, 86 points, you could win a game. Well, now it's become more of a 365-day a year job. You've got kids coming out of high school, they've got skills coaches. They're doing repetitive movements over and over and over again. So you're seeing people, we would do medical reports, kids coming in the league at 19, 20 years old with Achilles tendon changes and meniscal and cartilage changes that you would see in a guy who'd been in the league for 15 years. So I think that's not so much the soft tissue end of it, but you'd see people coming in. There's a lot more rubber off the tires when they're coming in. You also have a proliferation of development coaches. This is not a knock on development coaches. I think they do a great job. But you have your practices, you work these guys hard. Then on the lower players, how do they make their name? They're going to work these players more and more and more to show how hard they work them. So is that being tracked? We had some players who didn't play who would have 2 to 3 times the mileage and the accelerations, high speed, acceleration, deceleration, things like that, that the starters had. And they never got off the bench. So I think there's factors in the volume off the court. I think there has to be more coordination between the medical department and the strength department. That was one thing that I thought we did well in Detroit was really have some coordination. Everybody was together sharing ideas so that, for example, if I had somebody that I saw something on the table and said, we need to target this, I would talk to the strength coach, say, hey, what was your plan for today? Boom. Hey, I want this area targeted. Okay, we can incorporate this. And we work together and trainers, therapists, strength coaches, we all had inputs on every single guy. So if you worked with a particular athlete, I would want KPIs from you on a regular basis saying, what are you seeing that's missing? For example, do they have patellar tendon issues? Do they have hamstring issues? What are you doing to target it? What am I doing to target it? And we would share that information so that we know I'm not doing a bunch of stuff and then you're doing a bunch of stuff and it's overlapping. We're not really getting what they need. So I think communication is part of the problem. I think the schedule is part of the problem with travel. I think making sure from a dietary standpoint, from a nutrition standpoint, a hydration standpoint, a recovery standpoint, there's a lot of factors that can play into that. But I do think having just a simple coordination between the staffs and also separating what is actionable from the noise and being proactive, having the communication ability to say, hey, on this person, hey, maybe we've got to give them a break in practice, or we've got to make sure we hit a little bit more in the weight room to get them ready for this. Because we all know about load management, but I also think load management is you have to do enough to withstand the load. It's not just rest. If you don't get the work, you're not going to be able to tolerate it on the court. So kind of a long-winded way, but I think it's multifactorial, but I do believe there's a lot of information that comes across as information, but there's nothing you can do about it. And to me, if it's not actionable, that's great. Let's focus on what we can improve.
All right, I love this. This is not what I expected, but I love this. Because first thing, I think everybody's using this term load management, but not a lot of people, strength coach, PT, or whatever, actually understand the concept of load management, right? You just mentioned load management is not just doing less. You need to build up the base so they can do less, right? And another part related to this is like, all right, I think it's 6 months ago or like even longer, like maybe 8 months ago, Paul George and Kevin Garnett, they had their own podcast. And
Mhm.
they're talking about like why do we have so many Achilles tendon in the past few years? They used to don't have that. And what they say is because guys used to practice a lot harder between games. But nowadays it's like walk through, like shoot around. They don't really do much. But if you ask like sports scientists, strength coach, whatsoever, they're gonna say like the speed is actually a lot faster than 90s, than 80s, 90s, or even early 2000. So what are your thoughts on like this?
Well, I think you can practice as hard as you want. And I think anybody you're in the game, you know this. You cannot mimic game speed in practice. I don't care how hard you practice, it's not the same as the game. So mimicking that isn't going to happen. And I don't think that practice load alone is going to do what you need. I think there is, as we know, tendons, you load tendons, it takes X amount of hours for the tendon to remodel and reshape. So it's not just practice time, it's appropriate weight room work. I mean, I do think you need proper loading in different angles, 3D type of strengthening. That's an important part too. So, do they practice harder? It depends. When we had Coach Casey, boy, we practiced hard. We practiced hard. And I've seen other areas where they don't practice hard. Could it be a factor? Possibly, but I think that's a simplistic answer. I do think it's not just basketball loading because what if somebody doesn't have enough ankle dorsiflexion? What if they are tight and now we're going to head to practice? Well, now you're loading that tendon differently, aren't you? Whereas we make sure you're moving right, make sure your range of motion is good, and now we're strengthening you appropriately with good loads, overloads, and then getting the court work. So I think it's you need all these things together to really target that. And then I would also say don't wear number zero, right? Because that was three guys with number zero tore their Achilles. So, it's again, it's one of those things too, cause and effect. And sometimes things happen. I mean, you look at, wow, Achilles ruptures are a really big deal. Yeah, it seemed like a really big deal last year because you had Tatum and Halliburton uh,
Damien.
and Dame go down, right? Well, what about in the 2 years before that? How many Achilles tears did we have?
I
I
think a year before that was zero.
Yeah. So did everybody just change the way they practice? Sometimes shit happens, and if you look at a narrow window, and you got teams fighting for the playoffs now, Tyrese Halliburton. If it wasn't game 7, would he have gone out there and played? Probably not. But you know what? I can't fault him for that. I respect that he was just like, let's go. Possibly the same thing that happened with Kevin Durant when he was with Golden State. It's one of those, I'm sure that plays in. I wasn't part of the decision-making process. I don't know, but I can speculate that, hey, it's the championship. That's the athlete mindset, right? Um, but I also think that when you look at data in a compressed area, in a compressed time frame, you can get something that's misleading. Whereas if you look over a 5-year period, do we really have an overload of Achilles tears? I don't think so. I mean, I'd have to look at the data, but I think kind of a fluky thing. I find it hard to believe that big minutes guys like Tatum and Halliburton and Lillard were not getting enough court time. I would find that hard to believe. So, and I read somewhere where somebody said, it's because they need to do calf raises. Okay. Yeah, because nobody does calf raises right in the NBA. It's like, come on now. I mean, soleus is one of the most important muscles you're going to target. So yeah, I don't try to solve the mystery, but I do think you have to look at a longer period of time to really come to a decision on, hey, maybe we're doing something wrong. No, doesn't mean you don't look at it based on what happened, but I do think, again, maybe there was that instigating injury. Maybe, like I said, maybe some range of motion was lost, and hey, at this point in time, you know what, we're not doing a lot. We're just trying to recover and get you on the floor. I don't know. I wasn't part of it, but it's not that simple.
Nice, nice. All right. So, uh, outside of just Achilles tendon, um, because my experience, well, I came from Taiwan, so I have different experience. I work with like PTAT there,
Mhm.
and my experience here is like I feel like when someone complain about knee pain, we only look at the knee. When someone complains about low back pain, all you do is just mob the low back. When someone complain about hamstring, all we do is like fucking load that hamstring. All right, so the question is, throughout your 34, 35 years of experience, is that always the case?
I see it. It should not be. I remember When I started in PT school, simple rule, check the joint above and below. I'll never forget when I went to a sports medicine group back in the days when I worked with Health South, and there were these sports therapists, and they did shoulders, they did knees. I don't mess with the spine. I said, so if somebody's got a shoulder problem, what do you do about the neck? We don't treat the neck, we just treat the shoulder. Well, that's going to be a problem because a lot of shoulder problems that I see are related to the neck, a lot. So I think just simple rehab, the basics of rehab. I don't care if you're a PT, an AT, dual credential, you've got to clear the hip above. To think that an issue in the foot is not going to affect the knee, the hip, or the back is flat out wrong. I mean, I'd say it's silly, but it's way beyond silly. And you've seen basketball players' feet. I mean, they beat those things up. A lot of them are flat foot. I mean, some of these feet are beat up. I'll never forget with some of the guys that I worked with, and I may have learned this, from one of the guys when I was with the Pistons, but they would get pedicures and just be like, interesting. And he goes, I make my living on my feet. You take care of your feet. And I remember that. I worked with a collegiate guy and his feet were hurting him. And it was all this, hey, what do you think about this? I said, I'll tell you what, I'm going to work on this. Go get a pedicure this week. I said, and the same thing, what I heard from this vet, you make your living on your feet, you take care of your feet. He went and got the pedicure. And I said, what'd you think? He goes, I got an appointment next week too. So it's like, oh my gosh, take care of my feet. So yes, I can't tell you how many knee problems I've seen that have been something as simple as, again, not to keep bringing up lack of dorsiflexion, but guys get tight, get a lot of stopping, starting. Sometimes you can get a little bit of a tailor shift, something with the navicular, you're not moving quite right. You lose some dorsiflexion. If you can't dorsiflex, how do you get that extra range of motion? You're going to get some knee valgus, an internal rotation of the tibia. Does that not make you more vulnerable to an injury? Does that not impact your hip? So it's, again, I agree with you. I think you need to make sure that you have enough, not just skilled. And you brought a point up earlier. Everybody now has a DPT. And it was funny. Early on, I didn't. When I first started in the NBA, I did not have a DPT. And it was just like, oh, well, you don't have a DPT. I was like, yeah, you're right. I only have 30 years of experience working with grandmothers, athletes, people who you name it and they do it wrong. And I can figure out those people. It's when you can get those people better, man, an athlete's a piece of cake because they take care of all the little things. So I think sometimes people are coming in and they don't have the real world experience of, you know what? Stop looking at these people as Superman and, oh, it's the knee. We've got to fix the knee. The body as a whole. Sometimes you could have gut issues. Sometimes it's something as simple as you're not sleeping right and that's affecting your response. You're not recovering. There's a lot of different factors. It's a whole human. Everybody's different. You've got to figure that out. And I just think you have to have some real world clinical experience to tie that in to the athletic population as well. And I think coming right in and it's great if you had your residency and you're right into there, but I think you need some time working with normal people. We had a guy with Detroit. I won't use his name, but he will be a Hall of Famer. And he was very leery because of an experience he had with another team. He was very leery about working with team staff because he was told at one point his injury, hey, looking at the time, it's been this long, you're good to go. And he's like, I don't think it's right. It's been long enough. This is recovered. You're good to go. And he's like, I don't think I'm right. And it created a rift, and he and the team were never the same. Well, then I told him, I said, hey, man, I know somebody that you worked with. Here is my background. I worked with normal people for years. If I think something's good and you tell me something's not right, my job is to figure out why it's not right. You know your body better than me. I have to make sure the puzzle pieces fit. So if I think this looks great, but you've just thrown in this one piece that doesn't fit, I don't just say, well, that's an odd piece. We don't need it. That's a hint. And to me, that is what I enjoy about physical therapy in general and sports therapy in particular is I like figuring it out. Like what is not right? I was working with a guy in Toronto, had a knee issue, and it was just we've got to get him stronger. We got to get him stronger. Well, he couldn't do a reverse lunge without pain. In fact, he couldn't lay on his back and straighten his leg without pain. We've got to get him stronger. You can load him up all you want, but if it hurts, he's not going to be able to do it, and he's not going to get stronger. I mean, right? If something hurts, your body's not going to recruit the muscles. So we had to find what's not going right. So we just started watching how he moved, checked everything out, got him moving right, and then suddenly we do a lunge, it doesn't hurt. So we say, let's make it a drop lunge. How does that feel? Drop lunge, and he looks at me, does it again, looks at me, and I'm like, what? He goes, he does it again. He goes, that doesn't hurt. I'm like, it's not supposed to. You're a professional basketball player. You should be able to do this. And it was basically, for whatever reason, he had developed a movement dysfunction. We loosened up what was tight, strengthened what was weak, got him moving right, and now he can load the joint and it doesn't hurt. Now, was it a knee problem? Not really. I mean, it was, but that wasn't the cause. That wasn't the source of what was causing him to not be able to play. Take that out. It's again, what isn't working? It's Gary Gray used to teach courses, and what I loved about him was he had this simplistic way of doing things where he would say, like, okay, I'm Eric's knee. Okay, this is what I feel. Okay, why would I feel that? And he would go like, well, what happens if I do this with my foot? What will that do? What if I fire this muscle? What will that do? What if I do this with my, and all these different things? Really simplistic, but you start realizing they all have inputs. What is that piece? And that to me, that's the fun in sports. And yeah, so I think again, kind of went down the road on that one a little bit, but I do think if you're going to do this right, unless I'm standing there and I watch somebody come up with a bat and hit you in the knee, and I say, like, okay, that was a trauma to the knee because I watched the bat hit you. You've got to see what else is going on here. You've got to clear the foot ankle. And I don't care if it's a non-contact injury. It could have been fed into from the hip, from the back, from the ankle, from the great toe. You've got to break it all down. And that's what we're supposed to do. I mean, to me, that's the basics of sports rehab right there.
Nice, nice. I love it. I didn't know. Well, actually, when you mentioned like load the body 3D early on in our conversation, and I kind of like figured that you're probably a Gary Gray guy. I love his stuff. Like,
Yeah.
so I'm actually going through my gift journey right now, but that's not a point. So my next question is, all right, let's say um if a guy have knee issue and he said I don't know, all right, let's say everybody said he had a patella tendon pain. All right. So usually in my experience, like if this guy had patella tendon pain, we could probably do leg extension that could probably help or some sort of ISO,
Mhm.
right? All right. So so we tried that. After we tried that, let's say he was able to do single leg extension I think 120 pounds for like 20 reps. Then after that, after like just after a week, then all of a sudden he wasn't able to do 55 without pain and it's sharp pain. I'm like, hmm. And deep down in my gut, I feel like this is not just some sort of tendinopathy. So I'm trying to look at it, find a different way, but I just don't know, right? Because like we're playing, it's the schedule's super hectic, travel sucks. So
Mhm.
my question to you is when you have that, like, when you have some sort of like tendon pain, but it doesn't seem like a normal tendon pain, what would you look into?
Well, there's different things. So first off, obviously you go with the lowest hanging fruit, right? So if somebody, you try to figure out how did this start. So if it's a true tendon pain, typically it's going to be something that builds up over time, right? And just like any tendinopathy or tendonitis, you're going to get after the game, it's a little sore, but it goes away and then the progression changes. So history is going to be one of the first things we check. And then that directs us, okay, let's check the tendon. If we're going through the tendon and we're finding that's not really making the difference, well, then I look for different things such as is the joint moving properly? So if, for example, they have a rotation, if they've got a anteversion at the hip, for example, or if maybe they've done something and their tibia isn't rotating as it should, will that load the tendon more where you will feel pain in the tendon, but it's not really a tendon issue? And it sounds like in your case, they were doing fine and then it retracted. It doesn't sound like the progression I would expect with a tendon. So then I may look at that and say, okay, is that the problem? Is it the antagonist muscle is over responsive and that's affecting dynamic movement, which is causing the tendon to have to work more? Clear that. Something neurological. I look a lot, especially if it's in the hamstrings. I look for, I'll do a slump test. And if you're thinking about, say, a leg extension, in a sense, that's almost mimicking a slump test. So if you've got sciatic nerve tension, what happens? Things tighten around it. Your body tightens up to make it harder for you to load that tendon. And if it gets harder to extend your knee, well, you're not going to load that nerve as much. So could be something like that. Then you start going into, is there anything else going on? Maybe there is some kind of a systemic disorder or illness that we're not even thinking about that could present there. Now that would be something down the road, but if you're basically, what I would do in any rehab is you go, okay, the most likely thing is A. Check A. It's not A. Okay. Let's go to B. It's not B. Okay. If it's not A and B, what are the other things that could result in this type of symptom coming from above or below to lead to it? Clear that. And you basically just start eliminating options until there's nothing left. And if it gets to the point, I mean, I'll use an example. I had a guy, and this isn't a sports injury, but I had a patient back in the day and had a mild rear end car accident. Went to the hospital right after, and they're like, "You're fine." He's like, "I feel fine." About a week later, he sees the doctor because his neck's hurting. And I was like, okay. So he comes in. I'm like, whatever. You got a mild whiplash. I work on there. I do a screen. I do some therapy. Everything looks better than I worked on. Comes in 2 days later, exactly the same. No better, no worse. I recheck everything that I'd worked on. They all still look good. Okay. Let's check this, do some suboccipital, do some other things, blah, 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 work the thoracics. Everything's moving better. Comes in 2 days later, exactly the same. I'm like, it's not worse. Like if I did something that's worse, I'm okay with that because I'm on the right thing, but I maybe did too much or I did the wrong thing. Exactly the same. No better, no worse. I'm like, okay. Um, I've got maybe one more thing I can try. I'm going to try this. And I said, but then I want you to call me. Let me know better, worse, no different. Calls me. It's exactly the same. We're going through the history, and he had mentioned like it wakes him up at night. And then we started narrowing it down. It's about 2 or 3 in the morning. He wakes up with neck pain. I said, whatever it is, it's nothing that I can address. Go to your doctor. I call the doctor. I tell him what's up. I said, to me, it's not something physiological that I can treat. They did a scan. He had a tumor. Now, in a sense, he was lucky. That neck injury was just enough to create a problem where they found a tumor. I went through A, B, C, D, E, F. Nothing changed. Amen. And so going back to that, if it's something where I clear all my options and I've consulted with the other people on my staff going, what do you think? Because I think that's a nice teamwork. Like, hey, I think this. Have you tried this? Great idea. Let's look. But if you go through that, then sometimes you have to go to a doctor and say, hey, you know what? I'm kind of lost here. What do you think? And use the full spectrum. That's the beauty of being in pro sports is like when I was with Detroit, we had a great medical staff there. I mean, the docs there are awesome. And we would collaborate and learned a lot from them because we could work back and forth and be like, hey, I think this, well, it might be this. And we all work together to come with problems. So again, kind of a long-winded answer, but that's what I would do. I go through all the low-hanging fruit, and as I eliminate things, if it doesn't work, okay, that should start directing me towards something else. But if I get to the point where I've used up everything that I have and the rest of my staff doesn't have ideas, okay, maybe we've got to go to the film and see what we have there.
All right. Following question. And I know there's debate about these kind of stuff. What if, what if someone says, oh, he got pain because this muscle is not activated?
Show me. Show me. I mean, and I know where you're going. I'm not going to rip on any people, but I do think it's there's been people who do the muscle activation and helps. Again, I'm not going to get into arguments with people that do that. I would find it hard to believe unless there is an injury. Now, if you have a swollen knee, do I think your vastus medialis or your quads are going to fire as well as they normally do? No. That's physiology, right? Swelling is going to inhibit muscle recruitment. Uh, on the muscle activation, it's like I don't know how you play at this level if your muscles aren't firing. Now, could you move better? Sure. And again, I'm not an expert on the muscle activation, so nobody come after me for that. But I've never really been a big believer in that, to be honest with you. I think it's
My issue is like, bro, these guys play in the high level. Like, oh, all right, if this muscle is not really not active, how do you even stand? I'm like, bro, like, how do you even walk?
you would have had problems before this, right? If,
Yeah,
if a
yeah,
muscle's
like,
not working, you probably would have seen something before.
yeah, like,
And what muscle? I mean, if it's a now if you look and wow, one quad is a quarter the size of the other one,
yeah, then we can maybe,
you would have noticed that before though too, right?
yeah.
Um, but yeah, I think it's tough to do because it's again, if you were a runner, maybe maybe you get me on that because I do think some runners, I won't say they don't activate the muscle, but I don't think a lot of runners use their glutes enough. They become very hamstring dominant. And I think you need to do some work on targeting that. And sometimes it'll compensate over their quads. And they go in a straight line. Basketball players don't. Basketball players go every which way, forward, backward, side, rotation. I don't know a movement they do that wouldn't make a muscle respond. So yeah, I am, yeah, there are some areas that I am,
I, I got
I'm a healthy skeptic. Not saying it can't work, and you know what? I've seen people do some things that I think are absolute nonsense, and some people respond to it. And I'm not a big believer in throwing, voodoo at people and having them say, "Oh, yeah, that's great," because I think eventually it catches up, and at some point they're going to go to Dr. Google and go, "Wait a minute, this is nonsensical." Um, but yeah, I mean,
Yeah, I'm with you.
you
I'm with you.
can, but I'm like, you know what? It's again that would be if I was to go with that. It's I've eliminated every other thing, and the
Yeah.
scans are clean. Then I'm like, all right, let's give it a shot. You know,
I'm
let's
with
be
you. I'm with
out.
you. All right. I have I still have a lot of questions I want to ask you because I'm enjoying this so much, but I know like you're busy. So I'm gonna ask you a last question.
Okay.
So obviously you got a lot of experience in with high level athletes. You work with a pro organization for like 4 years. All right, if we talk about return to play,
Mhm.
man, people can hate me, but whatever, fuck it. Everybody's talking about fucking force play. Everybody's talking about force play. Like, all right, patellar tendon pain, patellar femoral pain, low back pain, hamstring, groin pain. Everybody's talking about force play. When like, all right, when when someone probably if someone have a hamstring strain, potentially like limited hip range of motion or like something's going on with their foot, right? Or when someone have like grown injury, it's probably like their pelvis out of alignment or if they have scoliosis whatsoever. Like, and you saw something on a force plate, like so. My question is, when you deal with injury, how do you build like your return to play testing? So it's tailored towards that specific case or that specific injury. Not everything's about force plate.
No, no, I think the force plate's a tool, and we both know Daniel Bove, and he wrote a great book on force plates. And I think force plates are a tool. I They have a value, and it depends on what you're looking at. And realize there's going to be some asymmetry, and that asymmetry may vary day to day. So, for example, if you put me on the force plate 4 days in a row, one day you may go, wow, he's really asymmetrical to the left. And the next day, wow, he's very symmetrical. And then the next day, I may be asymmetrical to the right. So there is some normal variation. So it's not an absolute science. But depending on the injury, you may want to see a rate of force development if you have a baseline on when they're good. So I am going to look at the key is in any return to play is that they should always be individualized. It should never be a cookie cutter. And depending on the position they play, are they a starter? What kind of minutes? The style of play? Those are all factors. And there was a great article that they had out in the Journal of Sports Physical Therapy a while back about starting at the end and working backwards. And I do think having a mapped out thing too tight doesn't work because sometimes you've given 2 weeks and they respond quickly, and then maybe there's another lull. So it's always based on your KPIs. Are they meeting the goals to move to the next level? I think having a structured rehab progression, you have to earn your way out of phase one, earn your way out of phase two. But then for the force plates, yes. So I'm going to look at, we're going to start building up running, for example. If it's a hamstring injury, we'll start with some slow running. We'll start adding some change of directions, and it may be just no sharp turns. You're just swooshing back and forth. Then we start to add some different turns, and we start to add some medium accelerations before we get into those. We're going to look at, okay, on the loading, and we visualize as well. It's not just the numbers, but we watch how they jump. What are their jumping strategies? So you're going to look at the force they generate, the rate of force development, gross asymmetries, and are those asymmetries consistent? Are they different from what they were before? We're going to look at muscle strength, and we're going to look at how they're doing in starting in small-sided games, working with the development coaches and some of the other guys, doing some 2-on-2, then to 3-on-3, and then maybe making that 3-on-3 go full court to see now we're going to open up some running a little bit, changing those variables until they can do what they need to do. And a lot of times I will take the athlete's feedback and ask, how do you feel? And a real simple question, can you do what you need to do? And they're usually going to be honest about that. And maybe I feel good. I don't feel like I'm not ready to do what I need to do on the court. All right, then boom, we keep going. So, I guess to go back to the force plates are a tool, and that is one of the pieces of information we'll use. But we'll also look, I mean, most of the NBA teams have connects on or something similar that we can track. So I can look at, hey, here's your max speed in a game. I need you to get close to that max speed. This is the normal mileage you're going to do in a game. So I want to see that kind of mileage in a practice, even though I know it's not the same intensity. I want to see that kind of mileage to know that your body's going to hold up. I need to see some accelerations and decelerations at speed that you have done. So we look at those metrics and we have the game data so they can say, I'm back. Not really, because you're running about 3 miles an hour slower and you're not stopping. You're just not putting on the brakes as we need you to do. So it's all this different information. There's no, if all you did was look at force plates, it's again, you're not seeing the forest for the trees. Hey, I'm gonna cook some chicken and I've got chicken. Well, what else do you use? Well, it's chicken. I don't need anything else. Well, there's more to it than just having a chicken. Return to play it's not necessarily complex, but it's not overly simplistic. I mean, at the end of the day, you have to see that they are capable of the same efforts, the same duration that they did when they were healthy, moving well, symptom free, not avoiding things. And everything else is just a tool to say, it looks like you're ready for this next spot. So I think looking at the force plates, that's something that, hey, our strengthening's working. The work that we're doing on the court and on the table are working because you see you're getting this, we're getting closer. We may do things where you go onto the force plate, just jump and land to see how you're sticking it. What kind of deceleration are you getting? That's great. I mean, that's again, all information to put together in the big piece and then individualize it that way. So we know how these guys are and what they've done and what they need to do to get back to where they are. And yeah, multifactorial, but again, force plates are a valuable tool, but they're not the sole answer.
Nice, nice. I love this. I love this. All right, that's all the question I have for you today, man.
All right. Thank you.